Okay. Um, so I am a geneticist, and the purpose of what I do is to try to take the DNA sequence. This is actually a real DNA sequence from part of the mitochondria, and connect that to the disease and see what we can find in the sequence that helps us to understand the disease and to treat it better. So it's to connect the genotype to the phenotype, the gene to the disease, and with the whole idea of treatment. So I'm going to start with a case report. I am a physician. That's what I normally think of myself as, although I have other hats I'll show you in a few minutes. Um, was a teenager when he presented to me. He had episodes of vomiting, headache, and dizziness that would last 5 days each. 3 days of each episode was in the hospital. Then he was lying down in bed for the next 2 days at home. They occurred exactly every 90 days. Sometimes they were 89 or 91, and on rare occasions between 88 and 92 days, but they were really completely like clockwork. And he did that for years, multiple years. He was ketotic during episodes, suggesting that there's mitochondrial dysfunction, which I'll get to. He had other problems as well. He is a syndromic patient. We'll talk about that later. What do I mean by syndrome? Syndrome just means things that go together. Usually people think about syndromes, cognitive delays, mental retardation, intellectual disability. He had that, but many people with syndromes don't. Sometimes people with syndromes, their face looks unusual. His did not, as you can see. Sometimes they have growth retardation. He's certainly not small. And sometimes they have birth defects. He didn't have that either. But he had syndromic in that he had multiple other issues. Here's some of them here: fatigue, frequent urination, reflux, constipation, choking episodes, and obstructive sleep apnea. The main issue was the random, aggressive, explosive behaviors were more of a problem than CVS. It required him to be institutionalized because out of the blue, for no reason at all, he would just rage and attack his parents. And that obviously caused a major disruption in his life. He failed treatment with all the usual stuff we use for cyclic vomiting syndrome. Nothing changed. He was having episodes every 90 days. So when we sequenced the genes, I found a variant in the sodium channel, S for sodium, CN for channel 4A gene. Now, this variant is not very rare at all. It's seen in 1.2% of the population. Like 1 in 80 people have it. But I've seen this variant in several other patients with cyclic vomiting. It's in the alpha subunit that's part of the sodium channel and let me just say from the onset right here, this presentation has two different purposes. Number one is I want to give education to the parents so you understand what's going on and can better treat your child. But number two, I'm hoping the researchers will hear this as well and to maybe give them some ideas as to where to go next. So every once in a while, I'm going to kind of veer off into the esoterical. This is one of those times. This is a sodium channel that opens up and lets sodium into the cells when there's a change in voltage. By letting sodium into the cell, it changes the voltage itself because sodium is positively charged. It causes a cascade of events. It's a vicious cycle. Once a channel opens, voltage changes, another channel opens, another channel opens. That's how nerves send impulses down the nerve, is that one goes off, another. It's a chain reaction. This is one of the channels that opens the sodium and causes nerves to do what nerves do. So this is a really key gene. And then there was another variant that was noted as well. Based upon this genetic abnormality, I put him on acetazolamide, which causes fluxes in potassium. I know it's very complicated, but if a whole bunch of potassium goes into the cell's going to need to deal with that, and it's going to pump calcium and sodium in the other direction.
Dr.
Yeah.
Boles, your slides are not progressing.
Oh, it's all on this slide. Sorry.
Are you?
Is this on Ryan? Do you see the guy?
Right. Making sure. Okay.
Okay. Yeah. It's right here. And I gave him acetazolamide, which is in green down here. And his aggressive behaviors went away entirely. Actually, this is an old slide. He's now in a group home and he's doing really well. He works sometimes. He assisted type thing. He goes to movies and everything, and he's actually living pretty much a normal life. He's no longer having cyclic vomiting episodes, and he no longer has episodes of rage. And this was based upon finding a common mutation in a gene. Now, the parallel here is that in the audience, you all know that you have a rare mutation in CHAMP1, but you don't know what the common mutations are, and those might be the ones that are most important for treating cyclic vomiting syndrome. Okay, here's my different, some of the different hats that I wear. I'm a clinician seeing patients. That's what I've done mostly for the last 30 years. I was 20 years at Children's Hospital Los Angeles. When I was at Children's Hospital Los Angeles, I also had a laboratory, a wet lab doing DNA work. I now write up patients based upon the DNA sequencing that I do and connect that to the disease. For many years, I was a medical director of sequencing companies, so I was the one that was in charge of making sure that they read the DNA sequences correctly and that we, what tests we made. I'm also coming to you as the Chief Medical and Scientific Officer of NeuroNeeds, which is a company that makes products for neurological disorders. I've made a lot of products for cyclic vomiting syndrome, and these are the products that my patients predominantly take, and they work so well. And I don't want this to turn into a commercial, but many of my products work extremely well in cyclic vomiting syndrome, and almost none of my patients have episodes anymore of vomiting. So those will come up, and then I do some expert witness cases. First of all, to step back, those of you that have cyclic vomiting know what it is. Those that are not, it's defined by episodes of nausea and vomiting. That's the definition. If you have episodes of nausea and vomiting and they meet these criteria, they are significant, stereotypical, and multiple, then you have cyclic vomiting syndrome. It's defined not on a lab test, but it's defined based upon symptoms. Episodes are significant. There's not just a little bit of nausea, a little bit of vomiting. These patients are extremely ill during episodes. And while they might have a little bit of nausea between episodes, it's much worse during episodes. They're stereotypical. Every episode is the same. Every patient's episodes are a little bit different from every other patient. But within a patient, they have a typical episode. In medicine, we call it stereotypical. Each episode is pretty similar to the others. Now, as the child grows up, they can change. Often they go from vomiting episodes to more migraine, headache-like things. And some episodes can be a little milder than others, but generally they're pretty similar. And then, of course, you have multiple episodes. If you go into the hospital with nausea and vomiting once, they say, well, it's a stomach flu or it's or you ate something, right? So food poisoning. Happens a second time, maybe. But what if you keep coming in 5, 10, 20 times? That would be cyclic vomiting usually. It's defined based on nausea and vomiting, but many patients have other things. They're almost all weak, lethargic, really kind of out of it. Abdominal pain can sometimes be worse than the nausea or the vomiting. Headache, light sensitivity, and sound sensitivity, where bright lights and loud noises cause some trouble. These are also common. So why it's defined by the top two in green, sometimes some of these other symptoms are as bad or worse, and there are often many of them are present, but they don't have to be present. The nausea and vomiting has to be present. It's just one of many functional conditions. Functional conditions affect the function of the cell, the person, but there's no structural change. You can do an MRI scan, you can do x-rays. I mean, you won't find anything. And so the functional conditions are very difficult on patients because, you know, between episodes, you don't see anything. And during episodes, the doctor will see somebody vomiting, but nothing else. Common laboratory tests come out normal. There are many other functional conditions, some of them like migraine, that you would recognize on this slide, other ones you haven't heard of before, but you probably know people with them because functional conditions are extremely common. Functional conditions are the #1 cause of disability in the world and in the United States. It's not cancer, it's not anything else, it's functional disease. Between depression, chronic fatigue, insomnia, bowel issues, migraine, you name it. These are the #1, and there's very little research being done on this, and not everyone even accepts them as being real, which is a big problem. If you have one, you have another. Usually people with one functional disease will often have another. That's not everyone. Some people have migraine and nothing else. Some people will have just depression and nothing else, or cyclic vomiting and nothing else. But most of the time when you have one, you have more than one. I didn't put everything on the poor elephant. The elephant's sick enough, and there's enough things on there to read. But, and of course, the elephant's lying down because of chronic fatigue. But so you might recognize, well, my child has more than one. And you may recognize that in your family, there may be some of these as well. People with cyclic vomiting syndrome often will have more functional problems, and often their first degree relatives and more distant relatives will have functional problems as well. Migraine being the most common, but not the only one. Migraine and irritable bowel, gastroparesis. These are not causes of cyclic vomiting, but they can cause people to vomit in cycles. They don't, so sometimes doctors will order tests, in particular, looking for malrotation, even though that's only about 1% of people with cyclic vomiting. It's severe and you need to repair it if it's there. Picture of malrotation, it's on the wrong side. But so if your doctor is ordering tests, that's okay. But none of these tests will be abnormal, or they'll just show non-specific changes in cyclic vomiting syndrome. So don't expect that these will make the diagnosis. They rule out other things which are more serious. And then you can have metabolic disorders as well that can cause it here. And then these are some of the tests that are ordered for that. Okay, I'm going to be showing you data. Some of it's never been seen before. Some of it I just put together in the last couple days, even in the last few hours. Regarding my research in cyclic vomiting syndrome, I keep updating my slides. The two pathways which I find most common are ion channels and energy metabolism. So what is an ion channel? This is a membrane in blue here. It could be a membrane between the inside of the cell and the outside of the cell, or the inside of the mitochondria, the outside of the mitochondria. There's many other membranes. And these membranes, ions are salts, like sodium and calcium, potassium here. They cannot get through a membrane. They need a door to go through. They can't go through the wall. They have to go through a door. A sodium channel only lets sodium in. People make it like a donut here, like it's a hole in the membrane, but it really is, it's a small door and a very large bouncer. Most of the channel, which is a protein, is the bouncer saying, we are a sodium channel. If you're not sodium, get out of here. You will never come through here. But the sodium only comes in when the cell wants it to come in. Okay, the door is closed now. All right, we're going to let 4 sodium in now. No more sodium going in. And then the door closes for a while. Okay, 5 more sodium in. So the bouncer decides when the sodium or the calcium or the potassium, and they go in different directions here. And by the way, this is an exchange pump. We'll get to that. Sodium goes in one direction, calcium in the other direction. But the bouncer decides that. What if the bouncer is distracted and looking the other way and the sodium just rushes through? That cell is really hyperactive now. It's way positive and all the channels will just suddenly go off and that cell will just go crazy. It's like, too many people into the party and they go crazy. It's my favorite metaphor for this. The mutations that I find in cyclic vomiting syndrome mostly involve leaky channels. For cations, cations mean positively charged. All these things here are positively charged. Positively
Testing.
charged cation channels.
Testing.
Okay, can you hear me? Yeah. Somebody said testing. Am I?
We can hear you, absolutely.
You can hear me now?
Yeah.
Okay. All right. Okay. Positively charged salts are cations. These are cation channels and they leak, letting too many cations in. And as I showed you from Ryan, sometimes they are common mutations. Energy metabolism. Why energy metabolism? Well, for one thing, once the sodium leaks in, or even in a normal person, once the sodium gets in, you need to pump it back out. Sodium will just go through here, but you need to pump it out using energy to get to the other side. Keeping the sodium out of the cell and then letting it in when the cell wants to do something, and then pumping it back out again. That takes up a huge amount of energy of the cell. That's actually one of the most important things the brain energy metabolism does. The head is hot, right? I mean, most people's heads are hot. You lose a lot of heat if you don't have a hat on, because the head is hot, the brain is hot, it runs very hot. It uses a huge amount of energy because it's electrical. And why all this electricity? The electricity is mostly pumping these ions out. So if the ions are leaking in, you need to pump it more. You need more energy, you run out of energy. So energy metabolism, the mitochondria, is critically important. So there's often a vicious cycle. If you have a mitochondrial disease, you cannot pump these out, and you have a channel problem. Your ions are in the wrong place. If you have an ion problem, you run out of energy. So they kind of, whatever one has the mutation, it causes the other, and then they go back and forth in a vicious cycle. And I'll show more of that later. Okay. I know this is complicated. This is more for the researchers, but I want to get across here is that many of the variants that contribute to disease and are treatable are not rare variants. They're common variants. And they're not necessarily in the variants that you think causes the disease. The CHAMP1 will cause the syndromic disease, but variants in other diseases will mean why you have cyclic vomiting syndrome. Now, I'm totally aware that a lot of people with CHAMP1 have cyclic vomiting, but many don't as well. Why do some do and some don't? Genetic changes in the rest of the DNA. The CHAMP1 predisposes towards it, no doubt about that. I have some ideas on that I'll show for the researchers. But other genetic changes push you the rest of the way. I've got some ideas on treating the CHAMP1 issue, but the main problem, main treatable, is these other genetic findings. And these other genetic findings are often common, and they run in the family. The CHAMP1 is usually a new mutation, right? Not in the parents. But these other ones run in the family. And family members with the mutations are often completely normal. In the absence of the CHAMP1, that ion channel mutation might not do very much. Or you may show what's called a form frust. That's a decreased. Just having headaches, maybe migraine, maybe not. Maybe some irritable bowel type stuff. Maybe a little gastroparesis where you fill up easy. Maybe a little fatigue. Maybe a little, but very commonly the family members that have the mutation are completely normal. Why? The rest of the genes in the environment. Sometimes they have the whole disorder. Sometimes family members have cyclic vomiting syndrome. Sometimes they have a related disorder like migraine. But I would say here, that's the most common, the form frust, mild manifestations. And these are all picked up by whole genome sequencing, which is what I recommend. That's to sequence all of the chromosomes in the mitochondrial DNA, all of the DNA, the whole thing. Here, and I just changed the slide this morning because on Thursday we made some changes to it. These are the genes that I know that are associated with cyclic vomiting so far. This is the latest one added to the list. The ones that are in green cause a lot of cases. I have a very large number of them in my practice. The ones that are in black, I have either a few cases or I don't have any, but yet they're in the literature. Like CHAMP1, I don't have any cases, but I know there's a lot of cases out there. I've seen the literature on that. I hear what you're saying, so I put it on here. So mitochondrial DNA, there's really 37 genes on the mitochondrial DNA. The rest of the 23,000 genes are in the nuclear DNA, but these 37 genes, I didn't want to list them all. They can cause cyclic vomiting syndrome. They cause problems with energy metabolism. There are other genes in the nucleus that cause trouble with energy metabolism, and these two are made common. This one is in green because I see it very frequently. Cation transport, that move cations from one side of the membrane to the other. The calcium channels, there's 3 of them, are the biggies. They are the most common causes of cyclic vomiting. Sodium channels as well. 4A is the one that Ryan had, but also 9A and 10A. And then there's the pumps that use energy to pump it back to the other side. They can cause a migraine-like thing with vomiting that can look like cyclic vomiting. Autoinflammation. The autoinflammatory genes are seen in cyclic vomiting, and I don't understand that very well. And then here's the syndromic ones. What do I mean by syndromic again? They have other things with them. They can have developmental delay, small size, birth defects, abnormal facies, organ failures. Nobody has all of those pretty much. They can have any combination of those, and certainly there are many other things that go to syndromes. I'm just giving you some of them. So these are the 4 genes which I know of that are involved in cyclic vomiting syndrome and syndrome. I don't have any CHAMP1 patients, but I'm going to show you one patient with PPM1D and one patient with POGS. And POGS is very similar to CHAMP1, and I'll go to that later. Okay, Molly presented at 40, no, Molly's now 42. I've known Molly for 30 years. She presented at 1.5 years old with cyclic vomiting syndrome. She used to have 2-day episodes. Photophobia. She don't like bright lights. She don't like loud sounds. Extreme lethargy. Would really like be almost comatose. They call it a conscious coma. Later on, they can remember what was told them. Whole body weakness, drooling and thirst, and every 6 to 8 weeks. Every single episode required hospital admission. She had these episodes into her adulthood. Every 6 to 8 weeks. She was put on amitriptyline eventually. It went to 8 to 10 weeks. Mild improvement, not really much of anything. As she was an adult and getting older, the episodes progressed. So there was less vomiting, and when she was in her late 30s, the episodes usually didn't have vomiting, only the most severe ones. But they had very severe headache, and she was out for 2 to 3 days, lethargic and weak. Everything here except for the vomiting. At age 41, the mother contacted me and said that, the episodes were now, she was having 1 or 2 a week. 2-day episodes, 2 a week, is half the time. Half the time she was in an episode, and she would barely get out of an episode, the weakness that happens before she got another one. And then you can see there are other things. Molly's syndromic. She has, faces is a little unusual. She's short. She has mild to moderate intellectual disability. And some other issues, very severe anxiety, some other functional problems. Started her before doing the DNA. Actually, we started her on the mitochondrial cocktail. The spectrum needs is my creation. It has 33 different active ingredients. The ubiquinol form of CoQ, a B100, which is a bunch of B vitamins, more B2, which is riboflavin, vitamin D, magnesium, and fish oil. And on this, her episodes dramatically declined. They went from 1 to 2 a week of 2-day episodes to once a month or less of half-day episodes. And these half-day episodes, she really is at home and not a big deal. She's just for half a day, she just lies on the couch or something. So she's not 100% better, but she's 90% better. And that was done in the mitochondrial cocktail. Put her on Zoloft, sertraline, and her anxiety got a lot better. This is another thing, is that the main treatment for cyclic vomiting, in my opinion, are over-the-counter cocktails, mitochondrial cocktails, and other over-the-counter vitamins, minerals, antioxidants, cofactors, etc. And sometimes drugs are very useful as well. Zoloft can sometimes be helpful in cyclic vomiting syndrome. It didn't do anything to her episodes, but it helped with the anxiety a lot. When we did the sequence, we found that she had a de novo that's not present in the parents, a frame shift, so that causes a stop codon which destroys the protein. This is the kind of mutation that says this will cause a protein problem. It destroys the protein in the PPM1D gene. This is pathogenic. It is diagnostic. It's in the stress response pathway for P53. It's a checkpoint in the DNA cell cycle, which really kind of fits with the POGs and the CHAMP1 to some degree, that they have to do with DNA replication. And the stress response pathway has to do with the mitochondria. Similar mutations, heterogeneous, that means one copy had the mutation, the other copy normal. De novo, not present in the parents. Sequence variants in this gene are associated with a syndrome which was just named very recently. And here, for those that want to, that's the PMI, the public PubMed identification number. The syndrome is an excellent match for Molly, because the syndrome and Molly have cyclic vomiting, reflux, constipation, developmental delay, hypotonia, broad-based gait, anxiety, myopia, that's like I'm not being able to see very far, wide mouth with thin upper lip, small hands and feet, small nails, and short stature relative to her family. It fit entirely. This is the syndrome of Janssen-de Vries, and it fits completely. And interestingly, of the 14 cases that are in the literature, 10 of them have gastrointestinal problems, and 8 of those are with cyclic vomiting. And so obviously that this is a cause of cyclic vomiting. Molly's the only one in my 80 patients that I'm going to be publishing soon with this, but clearly this is a rare cause of cyclic vomiting. Okay.
Um,
Another one.
sorry to interrupt you.
Yeah.
Since we're doing this kind of syndromic case report, I think that there are some questions from the audience that may be great if we take just a moment to answer them, as to see maybe if they fit into sort of this case report or not.
Okay.
Can you see them here, or would you like me to read them?
I can't see anything except for my slides.
Okay, so we had a one question that said, my son's stomach bloats regularly. His bowel movements are extremely large. He's nonverbal, so it's hard to determine if he's in pain or not. If CVS is common in CHAMP1, what is the likelihood that something GI is going on undetected? We live in Scotland, and the professionals will only look for something if he is acutely unwell.
Well, I mean, that would be a really long one, and it's a bit, I mean, I would say number one is that it's 100% there's something GI going on in there, because what you told me about is GI. And number two, it's not undetected. You're telling me about it. It's probably a functional disorder of the GI tract, which most of my patients have. I mean, over 80%, maybe over 90% of my patients have that. That sounds like kind of an irritable bowel type situation. Irritable bowel can be mild and it can be really severe. But it's based on symptoms, the diagnosis. And from that alone, it sounds like that there's something going on. Getting somebody to believe in it and treat it, that's more difficult. Okay, could I go on to Caitlin, or?
Sorry, and then just one last question.
Okay.
Would Zoloft help with repetitive behavior, since you had mentioned Zoloft in the last case study?
Zoloft is somewhat good for many cases of cyclic vomiting. It's not by far the best medication. I'll go over that when I get later. Zoloft is really, really good for the anxiety that these patients get. That's my go-to drug in people that have cyclic vomiting. That anxiety is a big problem, even if they're on other drugs, because the anxiety seems to just melt away in them. And they don't seem to get many side effects, if any at all, on that. And I've never seen anyone with severe side effects on that drug. So I recommend it. I mean, first I try natural things, the supplements and everything, and then you put the cyclic vomiting under control. And a lot of times the anxiety will go away because they're no longer vomiting, and their supplements will help. But if they still have a lot of anxiety, Zoloft is a good choice.
Thank you. Those are the questions so far.
Okay. Caitlin was in a study of mine 30 years ago when she was a kid. She presented to me as a 38-year-old. She had cyclic vomiting when she was young. She had 40 hospitalizations between ages 3 and 16. Then the cyclic vomiting went away. Sometimes it does that. Usually it doesn't, but sometimes it does. And she got ocular migraine 10 years later, and she had that when I saw her. Remember, I said a lot of times it does go from cyclic vomiting more towards a migraine. So this is one in which it just didn't go to migraine immediately, but there was a 10-year hiatus in there. Her complaint at age 38 was chronic fatigue. She was extremely fatigued, and it was really hard to do any work. Now, she is a high-functioning autism. She had a job. She also has learning disabilities, some OCD, developmental coordination disorder. She lived at home, but she was doing a part-time job, and she had friends, and she was just so fatigued. After a half day of work, she would just lie down and couldn't do anything. And that was her major complaint. And then we found a de novo variant in the POGS gene, one amino acid change to another. De novo, not parents in the parents. This is involved in cell division, and it's involved in many of the same aspects of cell division that you get in CHAMP1. If you knock down POGS1 in human cells, that means if you take a human cell and get rid of the gene, you get all sorts of problems in cell division. The nucleus of the cell actually starts to fragment. White-Sutton syndrome is the name that has been associated before with this. It has unusual features of the face and cyclic vomiting in 6 out of 16 cases. For brevity, I didn't go over all the different features here, but to say that Caitlin fits the syndrome absolutely perfectly. Okay, so this is what I said, is that cations, abnormal ion channels, are causing cellular energy deficiency. and cellular energy deficiency is causing abnormal cations. And this is the vicious cycle, and both of them cause hyperexcitability of the cell. And this is my model that has been presented at a couple meetings, but I have yet to publish. And I mean, this is where CHAMP1 likely fits in. Although they may fit in different places, causing cellular excitation. And then this is mostly for the researchers. CHAMP1 encodes a protein with a microtubule aspects that is involved in separating the chromosomes. You have to separate the chromosomes. When the chromosomes line up in cell division, and then they separate, and these are microtubules that attach to it to pull the chromosomes apart. Doesn't happen magically. And it's involved in that. And this is a very important process, not just in the whole body, but in neurodevelopment in particular. People with defects of microtubules or kinetochores usually have neurological problems. If you take the gene and you knock it out of a mouse, they have neurotransmitter genes go down, particularly GABA. And I think that this might be an idea of treatment that I have. Never seen a CHAMP1 patient. This is really for the researchers in the group. But GABA transport is downregulated. GABA is an inhibitory neurotransmitter. So when you bring down an inhibitory neurotransmitter, you have neuroexcitation. POGS, we've gone over that one case with Caitlin. POGS is associated with cyclic vomiting. It's involved in kinetophore and microtubules. It's involved in many of the same processes. So POGS and CHAMP1 both cause syndromes, they both cause mental developmental delay, and they both cause GI problems, including cyclic vomiting. So I think that makes sense. There's more data on POGS than there is on CHAMP1, so some of the data on POGS may be helpful for the CHAMP1 group. POGS does cause neuronal hyperexcitation. It's the balance of excitation to inhibition that's important. And this balance between excitation and inhibition seems to be off in cyclic vomiting. So the cells go into an excitation and you get vomiting and nausea. And this has been shown in POGS as per my model here about cellular excitation in this cycle. It hasn't been shown in CHAMP1, but CHAMP1 is so similar, it wouldn't surprise me at all. In fact, it would surprise me if there wasn't cellular excitation. And then if you take a mouse and you make it POGS deficient, you do see activation of excitatory neurons, which is again you see increase this, and over here you see decrease this. So in CHAMP, this is decreased. In POGS, this is increased. Maybe both of them are in both syndromes, I don't know. But it does seem to batter on that. So how is cyclic vomiting syndrome treated? If you look at the literature, these are the things that are usually used. This is now over 10 years old. I was one of the authors on it about the diagnosis and management treatment of cyclic vomiting syndrome. And these are the main ones that were in that article. Obviously, things have changed since then. How have they changed? Well, a lot of them are cation channels. And I find that high potassium diets, and here's some of the high potassium foods I pulled off the internet, help in a lot of patients. And if you notice that you give high potassium food, your child is better, well, then that's probably helpful. These are healthy foods anyway. In many of my patients, they can't eat enough bananas and guacamole. So I give them potassium chloride as a prescription, and some of them are on really high doses. And many of my patients have gone into remission on potassium chloride alone. They're on the cofactors as well. I do recommend DNA sequencing. Yes, you do know that you have the CHAMP1, but what else is there? What are the cation channel variants and mitochondrial variants? And they're all treated separately. Mitochondrial variants, the cation variants, they're treated acetazolamide versus propranolol versus potassium. And then the mitochondrial cocktail, they're treated differently. And then this is the machine that costs $1 million that can read the whole human genome in 4 hours. There's a lot of data, and much of this I wrote, showing that cyclic vomiting syndrome is involved in, that mitochondria are involved in cyclic vomiting syndrome. And one of the first things I do is mitochondrial cocktail, and that seems to help in a lot of cases. It helps in almost everyone. And in many cases, it puts them into remission. That means for long periods of time, months or years, they have no more episodes. What do I mean by mitochondrial cocktail? Well, these are some of the main ones, but there are many others. The problem is that energy is made on an assembly line. Here's what it actually looks like, the Krebs cycle in the electron transport chain. This is what you learned in high school biology. This is the actual electron micrograph, false color by a computer, of what it looks like. It's an assembly line. Electrons enter one direction, they exit the other. If you gave this guy his vitamins and he made cars twice as fast, you're just going to cause chaos. You're not going to make any more cars. So some people will give huge amounts of one vitamin. That's really not the way to go. You kind of have to give vitamins to the whole line. Or if this machine here got an energy surge, you're not going to make more cars. By the way, this is Ford Motor Company at the turn of the century, and this is Hyundai at the turn of the next century. Again, I don't want to make this a commercial. I made the Spectrum Needs It as 30 free active ingredients and include all the mitochondrial stuff, except for there's not enough CoQ, 2 different flavors. For people that can swallow, I do recommend Energy Needs. It's better. And it has a little bit more and it's a little bit cheaper. We don't have to worry about all the flavor and everything. CoQ is extremely important. You don't want ubiquinone. See N-O-N-E, you don't want the none. Stay away from the none. You want ubiquinol. If your CoQ doesn't say, it's the cheap one. That's this one. But this one's 5 times more bioavailable. It takes 5 times more of this to get the same blood level as this. Yeah, this is twice as expensive, but you think about it, it's a lot cheaper because you use a lower dose. This is a brand that I make because I was tired about all the brands out and there, people coming back and my blood levels of my patients would not be high, so I just made my own brand and I know that it works. But there are other brands out there of ubiquinol. This I said I have an idea based on the GABA. I don't know if it will work or not. The balance between the excitatory and the inhibitory neurotransmission is important in cyclic vomiting. It's important in POGs. It probably is important in CHAMP1 based upon that one paper that showed that there was increased inhibitory neural function. This is the synapse where the 2 neurons meet, one nerve cell, another nerve cell. Where they meet, they don't really touch. Neurotransmitters are released into the synapse. They're picked up here. Some neurotransmitters are excitatory. They cause the other nerve to go fire. Others are inhibitory. They inhibit the other neuron from firing. GABA is the key inhibitory neurotransmitter. When I want to change this balance, I give GABA and things that will increase GABA. It just happens to be that in that one paper, GABA is the one that seems to be affected in CHAMP1. So how do you do that? Well, you can give GABA, but most of it won't exit the stomach. I do it anyway because some of it does. L-theanine is what makes tea soothing. It's not the caffeine, it's the theanine that will boost GABA. 5-hydroxytryptophan boosts serotonin, which is another inhibitory neurotransmitter. And then B6 and magnesium help these to work. I used to have patients go and get these things off the counter and take them separately, but then that's kind of hard so I put them all together in what I call COM needs. So how do I put all this together? Cyclic vomiting is difficult to treat, and I really recommend that you get an expert to help you. Treat for mitochondrial dysfunction. Spectrum Needs or Energy Needs is the one that I make. There's a competitor, it's called ANRC. That is very similar. CoQ, ubiquinol form, and then other supplements that are individual to each person. If you want to change the excitatory to the inhibitory, I would use the ones that I showed you in here, these here. A lot of patients get extra magnesium because magnesium is easy to use. It's helpful on the gut, particularly if you have constipation. It's good for energy metabolism, and it's good for the excitatory inhibitory balance. Most of my patients are on high doses of magnesium. Do the testing to find the underlying risk factors because that changes the treatment, at least how I treat it. Medications I use under genetic guidance. I no longer just throw medications at people and see which ones work. That's the way everyone else does it. That's the way everything used to be done before we were able to read the genetics. I now give the natural stuff. A lot of times that's enough. Many times you need drugs, and I base that on the genetics. And then follow what's appropriate, and do not give up. CVS is treatable. Over 90% of my patients don't have episodes anymore, or they have episodes extremely infrequently.
Boles. I wanted
rather than cut you off with 100 questions, because I know that, like I said, this is an important
Oh,
topic.
this is the last one.
Sure. No. I just wanted to tell you that I wanted to let you finish, and I'll just have people reach out to you that have
Okay.
questions. I know we have.
Yeah.
So, sure. Go ahead. I'll let you
If you
finish.
if you haven't reached out to the CVS online yet, if you have cyclic vomiting, this is a great place to get information and for support. There's the website. And then here, this is how to reach me. If you're interested in the NeuroNeeds products, if you're interested in for me reading the DNA, if you're outside of the United States, I can read the DNA and help your physician. So you may want to contact this. This is the website, and this is the email here. Note that it's neurogenomics with an O and it's neurobility without the O. Everyone gets that wrong. I did not come up with this name, I promise. But here's the website, and here's the email. If you're interested in my reading the DNA or my being your physician, I can be the physician for people under age 30 that live in the United States. Otherwise, I can work with your physician no matter where you live and no matter what the age.